Good afternoon, my name is Dr. Calimano. Dave has asked me to talk to you guys and create a video with some little nugget. And this afternoon we have selected pleural effusions, which is a very common finding here on the ICU. And you guys probably are related to all the things that we order. And our intention is for you to know why we order those things so you can actually know exactly what we're looking for with it. Pleural effusions, we all have fluid on the chest, okay? It's usually about 50 mLs on each side and so on. And it gets formed and it gets reabsorbed to the lymphatics, okay? When there is an imbalance for any kind of reason, then you have accumulation of pleural fluid. The most common one is obviously the one that we see, CHF. On CHF, we see that usually the effusion, we have usually bilateral effusions, right usually greater than left. The second most common is right with the absence of left, and less common left effusion. So if you see that left effusion is less common to be CHF, okay? Now, what we try to do is once we determine that the fluid collection is big enough that we want to know why it's there, we want to see why is that fluid there, okay? And then what we do a thoracentesis and then we send some studies. You're familiar to these studies. The first that we do, things that we order and why. We usually look for that, looking for something called the Lyse criteria, the chemistry to start with, okay? We order LDH, total protein, glucose, amylase, and triglycerides. The Lyse criteria refers to the ratio of the pleural fluid to serum ratios, okay? And why is it important? It's important we take the total protein and the LDH. And what we do here is just LDH ratios greater than 0.6 and total protein ratios greater than 0.5 points towards an exudate. Less than that, less points towards a transudate. And this is the first stop, and is probably the biggest and most important one. Exudative effusions are more complex ones, are the ones that are related to infections, malignancy, and some other etiologies. Transudates is the most common ones, is the one that are associated to congestive heart failure, hepatic hydrothorax, which is fluid building up from the belly coming into the chest because negative pressure, positive pressure. And also, one less common, which is urinothorax, which is urine forming on the belly because of obstructive uropathy going into the chest. Those are the first things that we look at, the LDH and total protein, just so we can do the ratios and set the question that they're going to ask you, is this a transudate or an exudate? Transudate, usually you treat medically, you try to find the etiology. If it's cardiac, obviously you try to treat the heart, etc. Exudative, obviously you have to find, as I said, more complex etiologies. Glucose. Normal glucose usually is okay. Low glucose goes with empyema. And another one that you'll see low glucose will be when you have somebody with a collagen vascular disease, rheumatoid arthritis, etc. And they will have also low glucose. Amylase. On this instance, you can have problems because of pancreatic issues, fistulas, usually that effusion is on the left side, or rupture of the esophagus. Rupture, okay? Triglycerides. We ordered this one because we want to know if usually this effusion, you can almost make the diagnosis clinically because the fluid will come like a whitish fatty fluid, okay? How we distinct that? Okay, any triglycerides greater than 110, for sure you have what is called a chylothorax. And I'll tell you in a minute what that means. 50 to 110, you just don't know. And then you can order an electrophoresis. And if you have chylomicrons, for sure you have it. Then you have a chylothorax. Less than 50, probably okay. Now, what causes a chylothorax? Usually on trauma units, you see it on deceleration injuries. You stop the thoracic ducts rupture, and then you have it there. On this hospital, most commonly, since we don't have a trauma center, you will see it associated to lymphomas, okay? or any other type of malignancy that kind of attacks the lymphatic and the thoracic duct, but classically the lymphoma. On some other sides of words of the world or something, filaria is a zebra that will go into the lymphatic, rupture your duct, and then you get this. In Africa, you probably see it. Okay, then we order you cell counts. What we order the cell counts? Well, cell counts, device units, most ones will be neutrophils, lymphocytes, and eosinophils. Neutrophilic, high neutrophils usually points towards an infectious process, and pyemas will have high neutrophils, low glucose, and a gram stain that is obviously positive, okay? Usually we order, those things too. Lymphocytic effusions will pertain usually to malignancy, and then usually we have also some, nowadays we can also order some other specific studies for it. But lymphocytic effusions, you can see with that. You can also see on cases of tuberculosis as well. Eosinophilic effusions, you usually see with trauma and pulmonary embolism, okay? So trauma and pulmonary embolism, malignancy, and tuberculosis. Cytology obviously is one of the most helpful ones because it tells you, is there's fluid malignancy on the fluid or no. Now, a negative pleural fluid doesn't really exclude a malignancy because you can still have fluid without the formation of malignant cells or shedding of malignant cells into the pleural fluid. So malignancies will never really shed cells into the pleural space. So basically, all these things, you try to put it together and try to make a diagnosis of why is that pleural effusion there and how can we prevent for that effusion to form again. This is the 3-minute nuggets. Are we 3 minutes or?
We got a bit more, but we're good.
Okay, so
we're good.
Anyway, I'd like for you guys to learn these things in such a way that in the future when we ask you, you know exactly why are we asking this, and then you can always make your own diagnosis or differential diagnosis.
All right.
Thank you very much.
Thank you, sir.